Hello, my name is Paul Helland. I'm an anesthesia resident here at UCLA Medical Center. This video will go over thoracic epidural catheters for residents rotating any acute pain service. So this short presentation will cover a few things, including the indications for epidural catheter placement, some overview of some anatomy, where to get the equipment the first day that you show up, how to set the room up for success, an overview of the catheter kit itself for those that have never seen it, what to do once the catheter is in place, and a very brief review of medications and orders. This will not cover, however, some of the nuances, including mechanism of action of the epidurals, medication selection, i.e. which local anesthetic should you choose versus narcotic, how to manage anticoagulation and antiplatelets, of which I would refer you to the Azracoag's mobile application. It's like $3 and it's awesome. Will not cover troubleshooting epidurals post-operatively or during placement, nor the technique for epidural placement. All of these things you will cover on this rotation. So the indications for epidural placement are somewhat self-evident. You can use them as a primary anesthetic in things like C-sections. Post-operative pain management will be the primary use for epidurals during this rotation. However, I'd like to emphasize that there are intraoperative benefits, including partially suppressing or completely blocking the neuroendocrine stress response. The benefit of this for epidural catheters is maximized if the epidural is started before incision. Having the epidural in place during the operation, of course, will decrease anesthetic requirements, and epidural catheters can be used for chronic pain management. This is a really nice table by Dr. Grass in an article called Epidural Analgesia that you can obtain from Dr. Rahman that goes over specific surgeries and the levels that the epidural catheter can be placed at for maximum benefit. For completeness sake, it's always important to keep in mind some of the contraindications to epidural placement. Again, some of these should be pretty self-evident. If the patient refuses, obviously you're not going to stick a needle in them. If they have some sort of infection at the site of needle injection, a coagulopathy, or if they're on certain medications that put them at risk for increased bleeding, you want to be mindful of some of these contraindications. So we're going to do a brief anatomy review, emphasizing the anatomical landmarks that will be helpful for epidural placement, going over some of the vertebral anatomy with emphasis on the interlaminar space, since that's where your needle is going to be guided towards, reminding you of the differences between thoracic and lumbar spinous processes and how this impacts our decision to use midline versus paramedian approach, and also reviewing the layers that you pass through on the way to the epidural space. So this is a review of the anatomical landmarks that will be helpful as you examine a patient and decide where you want to place your epidural catheter, reminding you that the most prominent cervical process is at C7 and the inferior border of the scapula is T7. Of course, the superior portion of the iliac crest is L4, and we don't really use too much of the posterior superior iliac spine, but it's emphasizing that this is S2. The reason I included this picture here is on occasion, you will have to place an epidural catheter with a patient laying on their side, and maybe due because they can't sit up, maybe they have pain in the rectal area from cancer, maybe they're old and frail, so it's a good idea to practice finding these landmarks with somebody that can't sit up. So what are the layers that you pass through on the way to the epidural space? This is a really nice picture from Morgan and McHale's that shows that as the needle pierces, if you're going the midline approach, you will go through the skin, subcutaneous tissue, the supraspinous ligament, the interspinous ligament here, all the way into the ligamentum flavum, at which point you would enter the epidural space as you just passed through that. Now, there's differences between the between the midline and the paramedian approach, and with regards to what you actually pass through. If you'll notice here, on the paramedian approach, you actually will not pass through the supraspinous or the interspinous ligament. You will bypass those, and the only layer that you will go through outside of the skin and subcutaneous tissue will be the ligamentum flavum. Again, an important difference as you're placing thoracic epidurals utilizing the paramedian approach. So it's your first day on acute pain medicine. You have the patient list, you know where you want to go and what patient you want to put an epidural in. So where do you get the equipment? So the first thing you need to do is pick up the drugs from pharmacy. They'll give you a little fanny pack that will include the narcotics as well as the sedation, some Versed and whatnot. Next thing you need to pick up is over by room 15 in PTU. This is the epidural cart, and inside this is essentially everything that you need. It will have the tegaderms, the steries, it will have sterile gloves, it will have the epidural kit, you'll have little bouffant caps, as well as masks. So this is a one-stop shop, and this guy's mobile. So you grab this from 15. You also want to grab this, what appears to be like a massage chair in room 20, or by room 24 in PTU. Once you have all these things, then you can go to the bedside and you're ready to roll. Okay, let's talk about setting the room up for success. The ideal scenario in the morning time is to have your room set up just like the picture on the left-hand side. You want to be ready to roll, so your attending just has to walk into the room, put sterile gloves on, watch you place the epidural kit, and then move on over to the next one. Sometimes there's 5, 6, 7 epidural catheters in place. So you can maximize your efficiency by setting the room up just like this. The patient and the computer will be on the same side. And the reason for this is Sione or somebody else will help start the chart for the patient so it can capture all the vital signs during the epidural placement. Of course, the patient's going to be sitting on the bed, and the massage chair will be here. He will be on the other side with the bedside table as well as the kit. And we'll get a close-up of what's on this table in just a moment. So fix this in your head about what this should look like in the morning time. I wanted to point out that the massage chair itself needs 3 little caps on it for one part here, and one part there. But ideally, this is what your room should look like. Okay, let's talk about patient placement. So this is Tyler. He's a wonderful visiting medical student from my home institution, the University of Arizona. And he's helping us demonstrate patient placement. So you'll have him sit on the side of the bed. The massage chair will be here. These feet rests can go up and down to make sure that the patient, the chair is adjusted for the patient's height. And unlike regular massage chairs where you actually put your face in this, you really just want to put their forehead. And by doing this, it will help round their back out, as Tyler is demonstrating here. One of the assistants, whether it's another resident or wonderful nurse practitioner Sione, will stand here to help the patient round their back out to make sure that they're comforted and they know what's happening the whole time. So now you've got the room set up, you've got the patient in place. As you turn to the right, assuming that the table's on the left-hand side of the bed, you'll draw the curtain over the epidural cart here. And this is to emphasize what this is supposed to look like to give patient privacy during the procedure itself. Now on the cart, this is just emphasizing the other parts of the equipment that you'll need, one of which is some Versed. We usually draw this up for most people, assuming they're not old and frail. And we also obtain ephedrine because during the epidural placement, patients can either vagal down during needle placement, or you can have some side effects of the medication itself once it's placed. So again, don't forget your presser, don't forget your Versed. So this is a close-up picture of the bedside table. What exactly you need for your kit. You have the Aero kit itself, you have some chlorhexidine, sterile gloves for your size. You need about 4 to 5 of these larger size tegaderms and 1 set of these steri strips. Okay, let's talk about the contents of the epidural kit. This is a completely set up and ready to roll epidural kit. The one thing that's missing from this is the patient drape, which should be on the patient by the time your kit looks like this. But every time I placed an epidural, this was my complete setup ready to roll. So some of the contents that are worthwhile to mention is that what you want to do is open up the epidural kit itself. You want to drop some steri strips here. You want to drop the 4 to 5 tegaderms here because these are not included in the kit itself. The kit does include this syringe here with this filter. This is a test dose that has been drawn up in this syringe. It's got the lidocaine and epinephrine in it. This is the syringe for loss of resistance. You actually want to take this little yellow piece off here so it glides nice and smooth. This you drop saline in. This is a little syringe with a fine needle for creating a wheel to numb up the area. This here is a cap that goes on top of this epidural catheter once it's in place. Gauze for just cleaning the patient up. This is a sticker that says caution that goes on this cap here. And this, of course, is your TUI needle, which is the needle that you use to introduce the catheter into the patient's back. Lastly, this is a sticker here that we'll go over in just a moment to help secure the epidural catheter in place. But I've found that with muscle memory, that if you open up your kit, you familiarize yourself with what's inside it, and you set everything up the same way every single time, you know exactly what you're reaching for, when to reach for it, and it really facilitates placing epidurals easily. So now you have the epidural catheter in place. How do you secure it? So this is one way to do it, and I found this works quite well. So that sticker that I was mentioning in the epidural kit actually is a little sponge with a little slit down the middle that you can place. If your epidural is, say, coming out here at the top, you can place this little pad just below it. You can run the epidural catheter through this little slit, have it come out the bottom. You want to have this being held up in the air so it doesn't fall down and get contaminated. With the Steri-Strips, you can take a set of 3, and inside the Steri-Strip pack, there's 2 sets of 3. So if you run them one horizontal and one longitudinal, one vertical, one horizontal, it creates a nice seal around this little pad here. You can capture the wire, or not the wire, but the epidural catheter as it runs up as well. After that, you'll put a tegaderm over this, ensuring that each of the borders of the Steri-Strips are covered. You will run the wire up over the patient's shoulder, introducing tegaderms as you travel up along the way. You will put the sticker on the filter that I was referencing, and here's the cap attached to the epidural catheter, and then you will put a tegaderm over this entire part. And this is a complete taping done correctly. Okay, so now the catheter is taped in place. You're very excited, you got great loss, you're confident that your catheter is in the epidural space. Now what do you do? So I want to remind you of a few very important things. First of which is grab some ice, and what you usually want to do is get a cup of ice and put it in a glove, and you need to check for a level, which basically involves asking the patient if they can discern between cold and not so cold as you travel, maybe cephalad to caudad, wherever your epidural catheter was placed. And you can demonstrate to yourself that the patient has a good level. And you want to do this on both sides. The second thing you want to do is make sure that you have the epidural solution ordered. The local anesthetic that we usually use on acute pain medicine at Reagan is 0.1% bupi. The narcotic, depending on where the location of the epidural is. If it's more cephalad, we can use more highly lipophilic narcotic like fentanyl, so it doesn't have too much spread in a cephalad or caudad direction. Hydromorphone is more often used for lower thoracic epidural catheters, the level of which seems to be somewhat arbitrary depending on the practitioner. But again, I will let the attendings on the acute pain medicine go over that in more detail. Lastly, and most importantly, you want to follow up with the OR to make sure that this actually gets started. The worst thing that can happen in the absence of a contraindication to starting it, like refractory hypotension in the OR, is just forgetting to start it. And then the patient can come out and pack you, and they're in a lot of pain, and then everybody might look at you and say, what's going on with the epidural? These things need to be started. There needs to be time to allow the volume necessary to create the appropriate spread to cover the surgical area. And it's, again, even beneficial in the intraoperative sense by blunting that neuroendocrine stress response. So starting it early and ensuring that it gets started will not only benefit for all the reasons mentioned, but the patients will come out with less pain and PACU, and everybody will be happy. So in conclusion, the acute pain service is a great rotation. Epidurals themselves I find to be very satisfying to place, but extraordinarily difficult to master. With that said, just be kind to yourself and be patient. These things are highly technical, they're highly dangerous, and you have to be very careful. But once you get them down, they're so much fun to place, and the patients that get them benefit from them greatly. Lastly, thank you to my wonderful attendings, Dr. Rahman, Dr. Partanovid. While I was on service, you taught me so much. I hope one day I can pay it forward to future residents. And of course, thank you to Sione, whom without all of the residents and probably the entire acute pain service would be lost.